Hello and welcome everyone to another MMS info session. I know it's been a while since we brought this group together for one of these, and we hope that you've all been well since we last met. So as you know, these sessions are offered under the CMS Measures Management System contract, which is led by Battelle. I'm Brenna Rabel, and I oversee education and outreach on this project. Today's session is on a topic that we've gotten a couple of different requests to do, and it's on the topic of respecifying measures, specifically on turning claims or chart-based measures into electronic clinical quality measures, or eCQM. So as you know by now, these info sessions are part of an ongoing effort to engage measure developers and other measure stakeholders and quality stakeholders in quality measurement topics. That's an effort that also includes a series of newsletters, along with special announcement emails, public webinars, which I'll talk more about later, and then routine updates to the Blueprint and the Measures Management System website. Before we jump into the presentation, I just want to cover a few standard housekeeping items. The first is that today's session is being recorded. The second is that all participants will be muted during the call. We're going to have an opportunity for Q&A at the end of the call, during which time the lines will be unmuted for questions. But you can also enter your questions at any time in the chat or Q&A boxes that are available in WebEx, and then we'll get to those at the end of the call. I'll also mention that if when we do unmute the lines later, there's a lot of background noise, we may just remute and then move to the chat feature only, just to keep the background to a minimum. And then finally, the presentation slides from today's session are going to be posted on the MMS website, and that should be happening within about a week. So you'll be able to review all of the slides that are here. There's a few live links in here that you'll be able to click on when it's posted on the website. And then later on, we're also going to be posting a recording of today's presentation on the CMS YouTube page, and that'll be at a little bit of a later date if you want to share. And in the meantime, if you need the slides before those are available, you can always email us at MMS Support. So here's the agenda for today's presentation. We're just going to start off with a quick definition about what measure respecification or retooling actually is, discuss some of the rationale for why you might respecify a measure, give you some criteria determining whether a measure is even suitable for respecification, including a pretty deep dive into some of the feasibility considerations that you'll need to keep in mind. We'll talk through some other requirements, and then, just sort of give you an update on how that all fits into the overall measure development process. And then, of course, at the end, there'll be time for discussion. So it probably, as I said, makes sense to start the session off with a key definition. So what is respecification? In a nutshell, respecification, which you may have also heard described as re-engineering or retooling, just refers to cases when an existing measure is modified to fit a given purpose or need. And so, for example, a hospital measure related to bed sores could be respecified to work in the nursing home setting with relatively minor tweaks, or a visual acuity measure in a Medicaid program or a Medicare program could be respecified for use in the pediatric population. And then maybe the most common way that we think about respecification is when a measure is respecified to use a different data source. So in a lot of cases, what that means is a paper-based measure, which requires trained abstractors to collect information from the patient's health record, are often considered ripe for respecification into eCQMs, which are automated to collect information electronically from the patient's health record. And that's really what we're going to spend most of our time discussing today. So there are lots of reasons why respecification is considered for measures. In many instances, a given CMS program will require that new measures rely on EHR data and that they're generated with eCQM specifications as part of a burden reduction and modernization strategy. In general, it's considered to be less burdensome for measured entities to report on eCQMs once they're actually integrated into their EHR. So it's pretty common for programs to, think through how to move towards eCQMs. And then in some cases, respecification to an eCQM also requires measure developers to consider a different setting. So, thinking about a measure for the nursing home that might also apply to a home health agency, or something that maybe applies in the inpatient hospital setting to the ambulatory surgical setting, or a measure of a different population, so looking at a different age group or a different diagnostic category. Sometimes measures are even respecified for a different attribution level, so a hospital that was previously measured at the provider level might instead be respecified, at the hospital or at the group level, depending on how a technical expert panel interprets the specification. So really, the reasons why you would respecify a measure have a lot to do with how that measure is being used and how you think that the use case will change. And there are lots of factors that go into the decision about whether or not to respecify an existing measure into an eCQM. So a major factor is that you would need to consider the same NQS and CMS evaluation criteria that you would use to justify the creation of any new measure in order to consider whether it makes sense to respecify it into an eCQM. So, for example, would this new measure meet the importance criterion? So is the proposed eCQM applicable to the new setting or population that you're looking to measure? So thinking through whether that BedSores measure that I mentioned earlier, it might be intuitive that a measure of that kind would work in both an inpatient hospital setting and in a nursing home setting. But what if somebody were proposing it in an emergency department? Chances are that in your early research on the topic, you might find that the risk of it is so low in that population that such a measure wouldn't make sense there. So it's important to think about all of those things in the same way, regardless of whether or not it's an eCQM. The other thing to consider is, does this measure meet a quality goal of the new setting or population? So is there a reason why this measure needs to be respecified? Does it meet a gap? Does it promote alignment between multiple programs? You need to really be able to articulate why this measure needs to be respecified in order to move forward with respecifying it. And another thing to consider is whether the measure meets feasibility, the feasibility criterion. So for a new measure, when you think about whether or not to develop it, you're thinking about things like, are the data elements that I need available in this data source? Is this something that can be integrated into an existing workflow, or would a new workflow need to be built around this measure? So all of those same questions apply when you're thinking about whether to respecify an existing measure into an eCQM. You need to be able to demonstrate this to either CMS or to NQS if you proceed with endorsement. So really think that through. Once this measure is electronically specified, does it create any anticipated attribution-related challenges? So, for example, in a chart-based measure, it may have been much more straightforward for a manual abstractor to figure out which provider ordered a certain medication or entered a certain referral. But in an eCQM, if that information isn't readily available in a structured data field, you may need to reconsider your approach to attribution, balancing feasibility against the usability and scientific acceptability. It's also worth considering whether or not there's EHR saturation in the proposed care setting for the eCQM adoption. So, an eCQM for the home health program is something to think about. Do home health agencies typically use an EHR for data entry? If the answer is no, then maybe an eCQM isn't the right data source or reporting method for that measure. You also need to consider whether all of the data elements can be mapped to EHR data or specified in a way that's compliant with a current standard. So unless you're willing to specify a measure that relies on natural language processing like NLP, all of the information that you need to calculate that measure has to be stored in a structured field. So if getting any of the information that you need to calculate the measure isn't likely to be stored in a structured field and coded in a way that allows it to be electronically extracted, then you're going to run into troubles with that measure. So those are the sorts of feasibility considerations that you need to keep in mind when deciding whether or not to respecify. And now that's not to say that you can't respecify a measure that has feasibility challenges. Lots of measures have feasibility challenges, but those are things that you're going to need to look at and examine in testing to come up with a plan to mitigate them if you want that measure to be endorsed or used in a program. So another way to think about whether or not a measure can be respecified is to think about it in terms of a process flow. So if you're not the person or the developer who developed the initial measure, then the first thing that you need to do is to talk to the original measure steward to find out if they're okay with you respecifying their measure for that purpose. So a first step is to look at the measure concept you're interested in, figure out who that measure steward is. If it's CMS as the measure steward, then you probably won't have any problems because presumably CMS is the one who asked you to consider respecifying that measure in the first place. So if that's the case, then you would need to have it evaluated by a TEP and have them really look carefully at those measure specifications and confirm based on their technical knowledge whether that measure, can or even should be respecified into an eCQM. And if the answer based on that input is no, then chances are you're probably going to stop there. But if you get that TEP approval and CMS is on board with respecifying based on the feedback that you get from them and other experts, then you can move forward with respecification. And now that's not to say that your work is done and that once you've gotten one person to sign off on it, that you should absolutely take it all the way through the finishing phases of development, but that just means that you can start the process in earnest. And then the same goes, so if CMS is not the measure steward, then it's just that additional step of getting permission. And once you have that, you would go through the same general steps. So I will say that this measure lifecycle slide and graphic is very CMS-centric, but I do think that there are applications for anyone considering respecifying measures that can be gleaned from this. So once you've received approval or the go-ahead from the measure steward to respecify, the next steps are really to follow the measure specification and testing guidelines that are outlined in the blueprint. There's a ton of eCQM-specific information in the blueprint and in supplemental materials around it that are available to you to support that work. But it's really important to remember that just because the measure that your eCQM is based on has already been fully specified and tested doesn't mean that you can assume that your specified eCQM retains that same validity and reliability. All of that needs to be retested with the respecified measure for the new data source and the new population and whatever other changes that you've made to that measure. So I've already touched on some of this, but there really are just so many things to consider when respecifying a measure to an eCQM. You really have to think hard about how that change in specification format impacts how data are going to be stored and collected. So data elements from one data source, like claims or manual abstracted paper records, don't always translate one-to-one to the data elements that are going to be in an eCQM. So for example, a data element around diagnosis or evidence of, let's say, a diabetes diagnosis may be available in one or two fields within claims, but in the EHR, that information could be stored in lots of different ways. And if you don't want to miss any information, your measure really needs to be specified with that in mind. So when you're deciding where to tell the computer to look for certain data elements, you need to include any place in the electronic health record, such as in a medications list. If a patient is on insulin or metformin, that might serve as a proxy way to determine that a patient has diabetes. Also looking in a diagnosis field, a working diagnosis field, maybe a problem list, depending on how that information is stored in a given workflow. So it's really important to consider that when you're respecifying an eCQM. You have to think through all those different ways that a certain type of information might be stored so that you can be sure to include those in your specification. And that's a challenge that you really don't find to that extent with other data sources, especially those that rely on manual abstraction. So one really great way to make sure that you're thinking through all of those challenges is to use the NQF Feasibility Scorecard and to use it as early as possible in this process. If you're not familiar with the NQF scorecard, the Feasibility Scorecard, it is specifically designed with these types of challenges in mind. So essentially, you fill out what amounts to an Excel workbook that includes rows for every single discrete data element required for your measure, and you evaluate the feasibility of collecting each of those pieces of information in terms of a couple different axes of feasibility. So you'll assess data availability, which is self-explanatory. It's just whether or not that data element even exists in EHR. There's also workflow feasibility, which basically means, like, does this information get collected through normal clinical workflows, or do those need to be changed to accommodate the measure? There's also data accuracy, so that's getting at the likelihood that the information in the data fields that you're mining is likely to be current, accurate, and complete. And then the scorecard also has a column to help you think through whether a given data element maps to standard terminologies. So are the data elements that you're looking at currently mapped to an accepted data standard, like an ICD-10 code or a SNOMED or CPT code, and so on? So the feasibility scorecard is a really great structured way to get you thinking in those terms. But it's really just crucial that you not make any assumptions that all of the required data elements for the measure are in fact collected and stored in an EHR and in a structured field that you can abstract from. Assessing the feasibility for eCQMs requires lots of conversations, not only with clinical experts, but with representatives from EHR vendors who can tell you what is or is not possible in an EHR. But you also really need to make sure that you're talking to representatives from the measured entities themselves, so from hospitals or clinical practices, such as health IT experts or informaticists, or people who actually input the data for those measures to figure out if the data are actually stored in the way that you think they are. And it's really important to mention that, you know, those types of things vary a lot from hospital to hospital or from practice to practice. So it's really crucial to get input from people across different practices or EHR systems. So I've mentioned the concept of eCQM standards more than once, but I imagine that it makes sense for me to define a little bit more about what I mean there. So to address, like, disparate EHR, the way that information is stored in disparate EHR systems, you know, there are health IT standards and tools out there that are used for authoring eCQMs. And those standards are managed by the health IT community, usually via a consensus-based development process. And then those are adapted for use in CMS programs. So eCQMs are developed using a tool called the Measure Authoring Tool, or the MAT, which basically applies the clinical or the quality data model, or the QDM, and relies on a language known as CQL, or the clinical quality language, to help develop measures in a format that can be interpreted by all different EHR systems. And we'll talk a little bit about that format, which is the HQMF, a little bit more on the next slide. But what I'll say here is that the eCQI Resource Center is an incredible resource on eCQM-related tools and resources, including and beyond the MAT. You can also find information and links to other tools, including Bonnie, the CQL to ELM translator, VSAC, and Cypress. And if it feels like I've breezed through those definitions, don't worry. We are going to be talking more about each of these standards in some more detail in the next couple of slides. And we'll talk about how each of these fit together in the developmental process. So let's start by looking at the way that eCQM data are shared. So starting at the right hand of your screen, you know, we talked a little bit about the HQMF, or the Health Quality Measure format. So that's the format in which eCQMs are actually written. So that's what the measure authoring tool kind of spits out once a measure is specified. So it's, the HQMF is developed by HL7, which for those of you who are unfamiliar, that's just an accredited standards development organization. So the HQMF defines the information that's necessary to compute a quality measure and the resulting value, and it's in an XML data file format, which is machine readable. So an HQMF document provides the measure details that identify and classify the measure and provide important metadata about the measure. And those details include descriptions of things like the measure population, any stratifications, information about the measure steward, the measure type, the rationale, how the measure is to be scored, information about the value set, really everything that's needed to calculate the measure. And since last year, the HQMF is used with the CQL, so with the clinical quality language, to actually define the eCQM. So the CQL defines the measure logic. The quality data model is the data model that we use to kind of present the information, and then the HQMF defines the metadata and the population structure. So if you caught nothing else in what I just described, what's important to know is that healthcare organizations receive the measure specifications, which are expressed in HQMF using the QDM and CQL. So from there, healthcare organizations then report the results to CMS using yet a different format known as the QRDA, so the Quality Reporting Document Architecture. And again, the alphabet soup isn't super important, but I just want to give you a sense for how this information goes to and from these sites. So the QRDA is basically just a standard method to report quality measure results in a structured and consistent format that can be used to exchange the eCQM data between systems and to CMS. So there's an entire ecosystem of tools and resources that facilitate the use of standards in creating and implementing eCQMs. And we'll spend a few minutes on this slide really going through some of those tools to help highlight the things that you really need to know about if you're interested in dipping your toe in eCQM work. So I've already mentioned the MAT, which is the tool that measure developers use to generate their eCQM specifications. The Value Set Authority Center, or the VSAC, is a repository of official versions of value sets that support eCQM development. And the VSAC provides measure developers with tools to search existing value sets, author new ones, and maintain value set content consistent with current versions of the terminologies they use. And value sets that are in the VSAC can actually be referenced using the MAT to define measured data elements. So that's the connection there. Bonnie is a software tool. So, I'm taking, if you're on the left-hand side of your screen, I'm sort of talking you through these tools that are in the measure specification phase. And what Bonnie does is it allows measure developers to evaluate the behavior of their draft measures logic. So what measure developers can do is load their eCQM specifications from the MAT into the Bonnie tool and compare the performance of the measure logic against a patient test set to determine whether the measure logic actually aligns with the intent of the measure. So put really simply, the idea of Bonnie is just to make sure that the measure logic that's in the system is behaving the way it's supposed to, and it's identifying the right numerator hits, and that it's correctly eliminating patients that don't belong in the measure. So measure developers can rely on all three of those tools in the development of their eCQMs to ensure compliance with current standards and to make sure that their measures are being interpreted correctly. On the implementation side, Cypress is an open source software that's available to vendors to certify their EHRs and their HIT modules for calculating eCQMs. So it's an official testing tool for the ONC EHR certification program, and it works by generating synthetic patient records for the subset of published eCQMs that are selected for certification and testing. And the NCQA testing resource serves a similar purpose. So these are basically used on the vendor side to make sure that they're actually able to calculate and report on eCQMs to make sure that all the work that's done on the development side is being reflected in what actually gets reported out to CMS. So now that we've gone through some of the standards around eCQMs, I want to reiterate a little bit and dive even further into feasibility testing, which is a really crucial element associated with eCQM specification. Feasibility testing, which again should include the use of the NQF feasibility scorecard, must be done to assess feasibility and determine the extent to which the required data are available and retrievable without undue burden on CMS or on the practices that are reporting on them. The measure developers should be engaging stakeholders, especially HIT professionals, EHR vendor representatives, health informaticists, and clinicians. And you want to know as early as possible in the respecification process whether you're likely to encounter any deal breakers so as to mitigate the investment of resources. And I can't say this enough, you absolutely cannot expect the same performance results of eCQM testing as you might have seen from the original measure. I'm mentioning it here, you know, as it relates to feasibility testing, but this goes to all aspects of measure testing and evaluation. The respecified measure essentially needs to be treated as a de novo measure for the purposes of testing. So you may have heard of, you know, lean approaches or the fail-fast approach. You know, it's based on the idea that information should be collected early and often to determine whether a measure is viable at many steps in the development process, so as to avoid putting in, you know, months and months and months of work on something that isn't viable and that could have been identified as such much earlier in the process. So you can take this process map. Once you've decided to respecify a measure, developed draft specifications, and identified the necessary data elements that are required to calculate the new measure, then you have to consider these types of questions. So first, you know, is the data element likely to be stored in the EHR in a retrievable format? If the answer to that question is yes, then you can continue on. But if no, then you really have to consider whether that data element is a critical data element. And by that I mean that it can't be substituted with a similar data element or a proxy data element, and that the measure can't be calculated without it. You know, and if that measure is absolutely essential, then you really need to pause and start considering other options. But if it's something that can be replaced, so I mentioned earlier, right, if you are looking for symptom information or diagnosis information, you can be a little creative in terms of thinking about how to capture that data element in a way that's more feasible. So using proxy data elements, you know, information like what kinds of medications somebody is on to determine what sorts of conditions they might be dealing with when selecting, you know, measure exclusions. So I think it's worth doing that early work and thinking about the best ways and then follow-up ways that you can identify the data elements that you need or the critical concepts that you need before giving up on respecifying. But it's also important to note that if the critical data elements for your measure just frankly aren't stored routinely and in a structured way in the EHR, then your measure is probably not suited to being an eCQM. All right, and then these are just eCQM feasibility testing and points to consider. So I'm not going to go on this for too long because I think we've really touched on a lot of this already. But things to consider. So I've talked a lot about workflow, right? Will there need to be workflow or technology changes required for the eCQM? But things to think about in that regard are not just, you know, okay, do we add a field in our EHR to collect this information, but thinking about who in your practice or who in a practice or in the hospital is likely to be inputting this information. Do they need any additional training to know not only where to store this information, but how to best collect it? Is this information verified? Is this information in a different place? How many clicks does it take to get to the information that I need? And how does that impact patient care? So I think those are all the types of things that you're really going to want to assess qualitatively during early testing to make sure that you understand the workflow impact. The other piece is on, you know, will testing the eCQM show that it'll be limited to an integrated healthcare delivery system or an interoperable EHR system? So that's something that's super important with all measures, but especially eCQMs, is if you're looking at something like care coordination or looking at information being transferred from one clinician to another, from one entity to another, thinking through what the actual data requirements are in order to capture that. Is that something that'll work at any healthcare system, or does it have to be in one that's integrated that has a uniform EHR system? So that's another important factor to consider. And then it's also important to consider whether it's going to require data from more than one site to calculate. So I know that this has been a very dense presentation with a lot of information specific to eCQM. So I just wanted to make sure that you were aware of the resources that were available to you besides those listed here. So as I mentioned, the eCQI Resource Center is an enormous resource that's very navigable, that will link you to information about all of the things that I referenced today. I think if you're interested in learning more about the specific HL7 standards, so QRDA, HQMF, and CQL, you can certainly go to the HL7 page, which is linked here, but there's also descriptive information on the eCQI Resource Center about all of those things. For the eCQM tools themselves that I mentioned, so the MAT, the VSAC, Bonnie, the CQL to ELM Translator, and Cypress, again, you can click on those links to go directly to the pages that have information on those things. And again, there's some great graphics and some great information on the Resource Center for that information. And then for eCQM testing, we've included a link to the NQS Feasibility Scorecard here, as well as to a webinar on an introduction to eCQM testing on the MMS resources page that might be helpful to folks that are interested in getting started in this area. Another thing that I wanted to mention before we jump into discussion is that we have another webinar coming up next month. And what's super exciting about these webinars is that they are open to the public. They're not specific to just the folks that are ordinarily on our MMS info sessions. And the topic for this one is on understanding clinical quality measures, how CMS is modernizing its approach to digital measurement. So you'll be hearing from me, as well as Nicole Brennan, also from Battelle, and Kim Rawlings from CMS, learning about all of the different considerations around digital measures, which is sort of an extension of what's already being done around eCQM, thinking about issues such as interoperability and a lot of other, policy and technological factors that are on CMS's mind as we go into next year. So we're offering that presentation twice, once on September 15th from 2 to 3 p.m. Eastern Time, and then once on September 17th from 3 to 4 p.m. Eastern Time. So we encourage you all to join, to share it widely with your colleagues, and to reach out to us if you haven't received a link to that already. You can also find a link to it in the chat that we just posted in there for you. So we look forward to talking to you then as well.